especially compensation and especially the anion gap, delta anion gap and all. But they are not really as difficult as they seems to be. So that is what we are going to discuss, and we'll try to simplify it. So believe me, so if we understand the concepts clearly, even the toughest of the ABG won't take more than 3 to 5 minutes for complete analysis. So first we will be covering the theory part, and then we will see examples and case scenarios. So we'll try to make it a kind of interactive session. So you can give the answers in the chat box, and Dr. Gayatri will read out the chat box for me. So the problem is we don't have enough time. We have just exactly 1 hour. 1 hour this might get cut off. So we'll just directly start on. Okay. Coming to ABGs, so why do we do arterial blood gas analysis, or what all information does it give? So ABGs give you information regarding the acid-base status, regarding the oxygenation, and regarding the ventilation, that means CO2. And as we all know, the modern day ABG machines, apart from the arterial blood gas values, it does give you values about oxygenation. Just excuse me. Sorry for the interruption. Okay, so it does give values about arterial blood gas, the oxygenation status, the electrolytes, and the metabolites. Okay, so the modern day ABG, they also give you information about the abnormal hemoglobin types. So to find out any of these, we may do a ABG. So what is the importance of the pH control? So as we all know, our enzymes in our body, they work optimum at a pH of 7.4. Okay, this is very important for some tissues like myocardium, where significant dysfunction starts happening below a certain pH. For example, below a pH of 7.2, severe myocardial dysfunction starts happening. So we need the pH around 7.4 for the optimal enzyme activities. Okay, now how is the arterial pH regulated? So basically they are regulated by buffers. So the main buffer in our body is bicarbonate. Okay, so the 18% of the buffer action in our extracellular fluid is done by bicarbonate, rest by plasma protein, which includes albumin and inorganic phosphorus. So what is the role of respiratory system? So that is the elimination of the volatile acid, which is carbon dioxide. So respiratory centers in brain, they respond to changes in pH of CSF and blood to affect the ventilation. So when there is a acidosis, the respiratory center gets stimulated, and we ventilate, increase the ventilatory rate to eliminate the CO2 and to compensate for it. So the role of kidney, it is to retain and regenerate bicarbonate. So which may include excreting the acid load by hydrogen excretion, and also bicarbonate reabsorption, which happens mainly in the proximal tubule. Okay, so what are the normal values? So we know the pH, the value ranges from 7.35 to 7.45, but the optimal value is 7.4. PCO2, the value is 40, can range from 35 to 45. Bicarb 24 can range from 22 to 26. And PO2, the optimal value is between 80 to 100. So though the range, this is physiological, but what we have to understand is that for analytical purposes, for analysis purpose, we have to remember a single value. So our single value for pH is 7.4, PCO2 is 40, bicarb is 24. And we consider this as a single value and consider variation from this value. Okay. For analysis purpose, we need to remember a single value. Now, what are the potential pre-analytical errors? I'm not going to the detailed errors, but the common errors which include air bubble in a blood sample. So that if air bubbles get mixed, what can happen? It can lead to increased PaO2 and decreased CO2. Again, delayed analysis can cause consumption of oxygen and production of CO2. So which will be decreased CO2 and increased CO2. Now, venous admixture again will cause the same problem. It will cause decreased oxygen and increased CO2. Okay. Now, anticoagulant effect. So, ideally, nowadays, what is preferred is the pre-filled heparin syringes, which are meant for ABGs, which have dried heparin. That is the preferred one. Now, if you are not using if you are doing it by the conventional way of mixing heparin, the recommended heparin dilution is 1:1000 solution. 1:1000 heparin. This you have to take in a syringe. You have to flush out the syringe completely so that no visible heparin is left. Okay. So if some heparin gets overmixed, what can happen? That can cause decreased bicarbonate, decreased CO2, but there won't be any obvious change in pH. Okay. Now checking for the consistency of ABG. So this is based upon the Anderson-Hasselbalch equation. So this is just to check whether the machine is properly calibrated and standardized. Okay. So usually practically we don't do this, but this is just for theoretical purpose. If somebody asks how to check the consistency of ABG. So as per Anderson-Hasselbalch equation, the product of H plus into bicarbonate by PaCO2 should be equal to 24. So how to find the H plus concentration? So normally just check with the normal. Normally the pH is 7.40. So the 80 minus these two decimals, 80 minus 40 will be the normal H plus concentration. So normally it will be H plus into normal bicarbonate, as we all know it is 24, divided by PaCO2 normal will be 40. So you can see, so this will be 24. So this is the way how you can check whether the ABG is properly, machine is properly calibrated. Practically we don't do this actually. Okay, now we'll go to the step for successful analysis of blood gases. So the first step is we have to consider the clinical setting. So I would say this is the most important step. Okay. So we just don't look at the ABG alone. We have to look at what is the clinical scenario, whether it is an acute scenario or whether there is a chronic scenario. So we have to understand that and interpret the ABG accordingly. So first in a clinical scenario, for example, in a DKA patient, we know we anticipate metabolic acidosis. In Bartter syndrome, we anticipate metabolic alkalosis. So you have to anticipate, then look at the report and then interpret, then start interpreting. So the clinical knowledge about clinical scenario is very important. Okay. Now the second step will be, so we will be detailedly discussing all these steps. The second step will be what is the pH. So how is the pH moved, whether it is a acidosis or alkalosis. Then the third would be who is responsible for the change in pH, whether it is bicarbonate or metabolic or whether it is CO2 or respiratory. Okay. So once we find the primary culprit, then if it is a metabolic acidosis or a metabolic alkalosis, if we find that the primary disorder is metabolic, then the next step would be we look for the respiratory compensation. And in a metabolic acidosis, you have to look for the anion gap. Okay. Now, if the primary disorder is respiratory, then you look for the metabolic compensation. Okay. Now, next step is you look whether there is a mixed disorder. Okay, or whether is there anything suspicious of a mixed disorder. And last, you go look at the oxygenation and look whether the oxygen is adequate or not. Okay, so we'll go one by one. So what is the pH? So I told you for analysis purpose, we take 7.4 as a single value. So any pH below 7.4 will be acidosis bar acidemia, and pH above 7.4 will be alkalosis. Okay. So even if the pH is 7.4, it can be normal or it can be a mixed disorder or it could be a compensated disorder. Okay. Now next is we find who is the primary culprit responsible for the change in pH. So as we all know, CO2 we consider it as an acid, bicarbonate is a base. So once there is acidosis, first we look at the CO2, and if we find that CO2 is more than 40 and there is acidosis, so then the primary disorder is respiratory acidosis. Okay. And once there is a alkalosis and we find that CO2 is less than 40, the primary culprit is CO2. Okay. Now, after looking at the CO2, then look at the bicarbonate. Okay, so in which direction bicarbonate has moved? pH of 7.1, and you find that the bicarbonate is so it means that bicarbonate is the primary culprit responsible for the change in pH. Okay. Now, so what do you mean by respiratory and metabolic acidosis? It's a simple concept. So respiratory means the acidosis or the alkalosis is via the primary alteration in ventilation and resultant excessive elimination or retention of CO2. Now, metabolic means the acidosis or alkalosis, primarily it is because of the kidney, either by the excretion of H plus or by bicarbonate retention or bicarbonate excretion. So anything related to primarily affecting the kidney or bicarbonate excretion, that will cause metabolic disorder. Now coming to compensate. So as per body physiology, so whenever there will be change in the arterial pH, body will try to make it closer to normal, that is closer to 7.4. So that is what we call compensation. So what we have to understand is, though body try to compensate, it would be extremely unusual for respiratory or renal system to overcompensation. So overcompensation never happens. If there is a overcompensation, it means that there is some hidden primary other disorder. It's a mixed disorder. So disturbance, if there is a bicarbonate disturbance, that is if there is a metabolic disorder, body will try for respiratory compensation, and in respiratory disorders, renal compensation happens. Okay, so what is a simple disorder? It means that there is a single primary process of acidosis or alkalosis. Mixed disorder means there is more than one acid-base disorder occurring simultaneously. So what are the characteristics of primary acid-base disorders? So just to summarize again, so in a metabolic acidosis, we know that there is a decrease in pH and the primary culprit will be decrease in bicarbonate. So obvious compensation will be to try to decrease the CO2. So this is what traditionally all of us would have heard. The compensation happens in the same direction. So when bicarbonate decreases, what body tried to do? It tried to decrease the CO2 so that the pH get normalized. Same about metabolic alkalosis, the increase in pH, there is an increase in bicarbonate, so body tried to increase the CO2. Respiratory acidosis, there is a decrease in pH, the culprit we find it as increased CO2. So what the body tries? Body tried to increase bicarbonate so that to attain metabolic compensation. In alkalosis, respiratory alkalosis, there is an increased pH and there is some respiratory center stimulation which has caused to decrease to CO2. So body tried to decrease the bicarbonate. So compensation, once the primary pathology bicarbonate has decreased, so body try to decrease the CO2. So it happens in the same direction. So when we have to be alerted of mixed acid-base disease. So once there is absolutely no compensation, so physiologically some compensation should happen. If there is no compensation at all, or if there is a excessive compensation, it indicates there is some other disorder operating simultaneously. If there is a long-standing pulmonary or renal disease where the body cannot compensate properly, so that might also alert us for a mixed disturbance. Once there is assisted ventilation, for example, a patient with a metabolic disorder is ventilated and paralyzed, then there is no there won't be proper body compensation if the ventilation will be under our control. So that might cause a mixed acid-base disorders. Okay. Now, there are some settings which are conducive of mixed disturbance, some clinical scenarios. So, which may include, I'm just moving fast. So, for example, commonly metabolic acidosis plus respiratory acidosis. So, there are some scenarios where that can happen: cardiopulmonary arrest, pulmonary edema, some poisonings. Why in arrest? In arrest, because of poor perfusion, there will be obviously metabolic acidosis, plus there will be inadequate ventilation, which will cause increased CO2 retention. So, there will be mixed acidosis. Now, salicylate poisoning, we all know what it causes. So, it per se it is an acid that causes metabolic acidosis, but it directly stimulates the respiratory center. So, that way it causes hyperventilation and respiratory alkalosis also. Same can happen in sepsis also. Now, metabolic acidosis plus alkalosis. So, this can happen in renal failure patient with vomiting. Now, metabolic alkalosis plus respiratory acidosis, the classical example is cystic fibrosis. If there is a chronic lung disease with cystic fibrosis, so that will cause respiratory acidosis, and CF per se due to the loss of chloride and acid that can cause metabolic alkalosis. So these are some conditions where you have to anticipate mixed acid-base disorders. Now, metabolic alkalosis plus respiratory alkalosis, again, that can happen in critically ill patients. Okay. So now we'll just go through each disorder separately. So metabolic acidosis. So we know that. So what has happened? There is decrease in pH and there is decrease in bicarbonate. Okay. So the decrease in bicarbonate can be because of two reasons. One, it can be because of loss of bicarbonate in urine. Loss of bicarbonate per se causing decreased bicarbonate. So that is actually what we call normal anion gap metabolic acidosis. Second could be there is some extra acids in the body that has caused a extracellular buffering of the increased. So there is some extra acids which was buffered by bicarbonate, and this extra acids has decrease in bicarbonates. That is high anion gap metabolic acidosis. So the compensatory response would be to hyperventilate and decrease the CO2. So that is what we call acidotic breathing or Kussmaul respiration. Okay, now we are moving to compensation. So we'll try to simplify it in the further slides. Okay, so we'll take it by an example. Okay, so there is for example, a patient, let it be DKA, a patient with pH of 7.22, PCO2 of 24, bicarbonate of 10. So the pH is acidotic. We look at both CO2 and bicarbonate. So it is the bicarbonate which has decreased. So the primary culprit is the bicarbonate. So there is a metabolic acidosis. Now CO2 has also come down. So it has moved in the same direction of bicarbonate. It means the body is trying to compensate, but it has not succeeded because the pH is still not normalized. So usually, even if the body tried to however the body tried to compensate, the pH usually never reaches the normal. It might reach about 7.35, but it never normalizes usually. Okay. Now, so we'll try to find whether the compensation is, what are the different ways of finding compensation in a metabolic acidosis. Okay. So there are primarily there are three ways of doing it. So one is the simplest way would be just look at the last two letters of the pH. So that would be, so here it is 22. So that would be the unexpected PCO2 provided appropriate compensations happens. Okay. So our CO2 is 24. It has not normalized. So this shortcut holds true for both metabolic acidosis and alkalosis. Okay. So this is one way. It's a crude method. Okay. Now the other way would be, so what is the change in bicarbonate which has happened here? So this was consider it as 9. Sorry. Okay. So the degree of bicarbonate reduction, if it is 9, it is 24 minus 9, it is 15. Okay. So now the PCO2 reduction should be, one formula is 1.2 times the change in bicarbonate. Okay. So 1.2 times change in bicarbonate. So 15 into 1.2 will be 18. So that would be the expected change in PCO2. So the CO2 will fall from 40 by 18. So that will be, again, we get a value of 22. Now, the familiar method is what we call Windass formula. Again, the PCO2 will be 1.5 into bicarb plus minus 2. That will be again 1.5 into 9, that is 13.5 plus 8, that is 21.5 plus minus 2. So roughly same. So all three ways, so we can calculate compensation metabolic acidosis by all these three ways. So you have to remember this, there are many formulas related to ABG, but I think the only formula you need to remember is this formula. Okay. Okay, now we'll just move to anion gap. So what is anion gap? So it is basically a method used to assess the acid-base status in metabolic acidosis. Okay, so basically it is based upon the principle of electron neutrality, and the anion gap is so it is the unmeasured. You can just say unmeasured anion minus unmeasured cations. Okay, so how we calculate it is sodium minus bicarbonate plus chloride. Okay, so you in some textbook they add potassium also. The normal value will be 8 if you don't add potassium. So most of the standard textbooks, they give anion gap value without potassium. It is sodium minus bicarb plus chloride, and you take the normal value as 8. Okay, So what does it mean actually? So it is actually we don't need to get confused regarding anion gap. So it just remember it as if there is a high anion gap, it means that there are some extra additional acids other than what exists in the body normally. If there is normal anion gap and metabolic acidosis, it means that there are no extra acids, but what has happened is the body has lose some bicarbonate. So this is the normal, you can see normal anion pool, chloride, bicarbonate, and some unmeasured anions. Okay, so this difference is the normal anion gap. So in normal anion gap metabolic acidosis, so what we see in a renal tubular acidosis patient, what happened is some bicarbonate. Okay, so the chloride has increased to compensate for that, and the anion gap. But as high anion gap acidosis, what has happened is there is some extra acids which was added to the anion pool. So that's why the anion gap has increased. Okay. So the bicarbonate is increased because of these extra acids which buffered some of the bicarbonate. Okay, for the differential diagnosis, so this you need to remember for your theory exam as well as practical. So you know what for elevated anion gap, just remember there are some extra acids. So this is the commonest mnemonic what we use, Kusumol. So K stands for ketoacidosis, B DKA or starvation ketosis. Then uremia, starvation, then salicylate poisoning, methanol poisoning, alcohol, lactic acidosis or septic shock. Any shock causing lactic acidosis, you will have a high anion gap metabolic acidosis. So all this means there are some extra acids. So normal anion gap, the mnemonic is diarrhea. So in diarrhea, what happens? We are losing bicarbonate in the stool. Then renal tubular acidosis, we are losing bicarbonate in the urine. Okay. So we are using either in the urine or in the stool. The other would be ureterosigmoidostomy and ammonium chloride poisoning. Okay. So coming to respiratory acidosis. So in respiratory acidosis, what happens? Due to some disorder there, which is affecting the ventilation, where there is inadequate ventilation, which results in the increase in the CO2 level. And the compensation will be body try to increase the bicarbonate level. So this can the respiratory, any respiratory pathology, there can be two scenarios. Okay, the acute and the chronic. So in metabolic disorder, the compensation is by the lungs. So it happens very rapidly. We start hyperventilating and the CO2 level start coming down very fast. Okay, but in respiratory, the compensation is done by the kidney, which happens by two mechanisms. One is rapid cell buffering, which happens acutely within 24 hours. The second is increase in the net acid excretion. So this happens, it's a chronic phenomenon. It takes time. So it takes minimum 48 hours. So there will be acute compensation and more compensation after a few days. Okay, in any respiratory disorder. So for example, for an acute respiratory acidosis, the classical example would be a pneumothorax. A patient who suddenly developed pneumothorax, you do ABG and you find a severe respiratory acidosis. So for a chronic respiratory acidosis, the example would be a chronic lung disease patient or a neuromuscular disease patient whose muscular efforts are less and who are chronically hypoventilating. So they will have a chronic CO2 retention, plus there will have a chronic compensation for the bicarbonate. There will have a very high bicarb levels. Okay. Now coming to metabolic alkalosis. So as we all know, so what it happened, there is an increase in bicarbonate, which is the primary pathology. So we divide is chloride responsive and chloride resistant. Often people confuse between these two terms. So chloride responsive means that the metabolic alkalosis is because of the loss of H+. For classically, the classical example would be a hypertrophic pyloric stenosis, where there will be repeated vomiting, repeated gastric juice. So gastric juice pH will be around 2. So we are losing acid in the body. That's why we develop contraction alkalosis. We'll develop chloride responsive alkalosis due to hypovolemia and loss of H+. In chloride resistant, the primary pathology is there is retention of bicarbonate. So body is accumulating bicarbonate, which is causing the alkalosis. That will be chloride resistant alkalosis. Okay. The examples are Cushing's and Bartter syndrome. So the compensation will be gradually body will try to hypoventilate and increase the CO2 levels. So the compensation will go to final. So you just don't remember this formula. Just remember this formula, which is 0.6 actually. So the change in PaCO2 will be 0.6 into delta change in bicarbonate. We will summarize the compensation in a single slide. So coming to respiratory alkalosis. So the pathology is there is a CNS, there is a primary hyperventilation. So classical example would be a patient who had a severe brain injury, for example a hypoxic ischemic encephalopathy, post-traumatic brain injury, who chronically they hyperventilates. Okay, so they have a low CO2 levels, so the body tried to decrease bicarbonate level and try to compensate for that. So easy tip for learning compensation. So I will tell you that it's not very difficult to remember all these values of compensation. You just need to remember these 6 values: 1.2, 0.6, 1, 2, 3, 4. So you just need to remember this. It's not difficult, right? 1.2, 0.6, 1, 2, 3, 4. So why? What is 1.2? So in a metabolic acidosis, the expected compensation would be 1.2 CO2 change per bicarbonate. In metabolic alkalosis, it's the half of that. So the expected change would be 0.6 CO2 change per bicarbonate. So again, it moves in the same direction. So in metabolic as bicarbonate decreases, so there will be a 1.2 CO2 change per bicarbonate. That 1.2 CO2 degrees per bicarbonate change. And vice versa too, in metabolic alkalosis, the change will be 0.6. So in respiratory acidosis, so again we know that acute and chronic, the compensation will be more. Okay, so in acute scenario, there will be 1 bicarbonate change per 10 CO2. Here it is 10 CO2, here it is 1 bicarbonate. So but in chronic, just excuse me.
Hello.
Sorry for the interruption. So in chronic respiratory acidosis, the acutely there will be 1 bicarbonate change per 10 CO2 and chronic will be 3. In respiratory alkalosis, the acute the change will be 2 bicarbonate increase per 10 CO2, and in chronic respiratory alkalosis, the change will be 4. So remember 1.2, 0.6, 1, 2,
Hello.
some technical glitches, extremely sorry for that. Okay, so we'll just continue. So just remember 1.2, 0.6, 1, 2, 3, 4, right? Now just if you want to assess the oxygenation status, we all know there are different measures. One is A minus A gradient, PaO2 minus PaO2, then alveolar arterial oxygen tension ratio, the PaO2 by FeO2 ratio, PF ratio. Then the other would, the latest would be oxygenation index, which will be mapped by mean airway pressure divided by BF ratio. Okay, so I will just summarizing. So first step will be look at the So first we'll be looking at the pH, then deciding whether it is acidosis or alkalosis, then look at who is the culprit, whether it is a respiratory or metabolic, then look at the clinical scenario and look for the compensation. Okay. And so in metabolic acidosis, determine the anion gap. In respiratory, look for the metabolic compensation. Then look at the oxygenation status, and in if there is a high anion gap metabolic acidosis, then we have to look for delta anion gap and delta ratio. So that we will discuss in a coming slide. Okay. So we'll from here we'll see different examples. So I will each of you can take 30 seconds. We don't have enough time. So just see this example and give your interpretation. Gayatri, please read out the chat box. Dr. Gayatri, any answers?
No, sir. Metabolic acidosis. Sir,
Okay, so I have a yeah. So I need more complete answer. So we'll discuss. So there is a acidosis.
compensated metabolic
so now
acidosis.
we look at. Okay, good. So we'll move on. So see, there is a acidosis. So the CO2 is lower side. We look at the bicarbonate. So it's a bicarbonate which is in the direction of the pH. So there is a metabolic acidosis. So in a metabolic acidosis, next we look for the compensation. So what would have been the ideally expected CO2 would have been 34, or you can you can calculate using the Windass formula or the formula we discussed. Change 1.2 into change in bicarbonate. So 6 into 1.2 will be the expected change in the CO2. So the ideal CO2, the proper compensation would have been less than 33. So you can call this partially compensated metabolic acidosis for completion sake with normal oxygenation. So we'll move to the next example. You can give your answers, just 30 seconds. So just consider this as an acute scenario, case of acute pneumonia. Dr. Gayatri, any answers?
No, sir.
Is the chat box enabled?
Sir, one respiratory alkalosis.
Okay, so it's not respiratory alkalosis, right? So
metabolic alkalosis by
so there is an alkalosis. So which type of alkalosis? So I will just make it clear again. So the pH is alkalosis. There is no doubt about it. Look at the CO2. CO2 has increased. The CO2, it is like so it is acidic side, right? But the bicarbonate is in the alkalotic range. So the primary culprit will be a metabolic alkalosis, right? So what will be the compensation in metabolic alkalosis? So as we discussed, the easiest way again would be to look at the last digit of 2 digits of pH. So in a primary metabolic alkalosis, had it been the full compensation, the CO2 would have been 59. Or you can calculate it as 0.6 into the change in bicarbonate. Here it is 24. Okay, from 24 it has moved to 48. So the delta bicarb is 24.2. 24 into 0.6. That will be the expected change in the CO2. Okay, so which will be roughly 14 or something. So the CO2 ideally would have been above 50, above 55, but the CO2 is only 49. So it is partially compensated metabolic alkalosis. So when you get a ABG, just write this. Just write 1.2, 0.6, and our 1, 2, 3, 4. Just write it in a paper and then start doing the exercise. Okay. Now third example. So first look at the pH, then look CO2, whether CO2 has moved in the direction of pH. If not, then look at the bicarbonate, then look for the compensation. Okay.
This is too fast.
Respiratory acidosis with hypoxemia.
I want better answer, more
uncompensated respiratory acidosis.
So when okay, so okay, so we'll move to the answer. So there is acidosis, no doubt about it. Respiratory, so the CO2 is in the direction of acidosis. So it is a respiratory acidosis, but the bicarbonate is 21. Then we have to calculate for the compensation. So ideally, in this case, you should have asked me for the clinical scenario, whether it is an acute or a chronic. Okay, so that was more important. Okay, so not really, so I just confused. So see, both CO2 is in the acidotic direction and bicarbonate is also in the acidotic direction. So in such cases, there is no confusion. So both CO2 is also in the acidotic direction and bicarbonate is also, had it been the compensation, bicarbonate would have increased, but rather it has come down. So it means that it is a mixed disorder. There is both respiratory and metabolic acidosis. Okay, so in such cases there is no need of confusion. There is no need to calculate even. Okay, so just look at in what direction both has moved. Okay, so if the CO2 had increased, for a compensation, bicarbonate would have moved in the same direction. The bicarbonate also should have increased. Instead of that, it has come down. So that means there is a different mix disorder. Okay, again, you can take that 1 minute.
So, compensated respiratory acidosis.
Doctor, any other answers?
Compensated respiratory acidosis with hypoxemia.
Okay, so again, so please understand, so the pH is not normalized, right? So pH is 7.28, so it is never compensated. So compensation means we are talking about the pH. So the pH is not 7.46, so we cannot tell it is fully compensated. Okay, so there is no doubt of it is acidotic. The CO2 is in the acidotic range, so there is a respiratory acidosis, absolutely no doubt about it. Then we have to understand what is the scenario. So respiratory acidosis, so we remember 1, 2, 3, 4. So this is respiratory acidosis, right? So imagine it is a chronic scenario. So there has been from 40 CO2 has moved to 80. So 4 into 10, right? That is the change in CO2. So 4 times 10 CO2 change. So what would, for ideal compensation, it would be 4 into 3. That is, the bicarbonate should have increased by 12, or the bicarbonate should have been 24 plus 12, which is 36. So instead of that, it's only 34. So that means it is partially compensated respiratory acidosis with severe hypoxemia. Now, even if you don't know this calculation, you can just imagine, okay, what would have happened, because bicarbonate is trying to compensate, you know that, but the pH is not full normalized. So it is partially compensated respiratory acidosis with there is hypoxemia. So coming to delta ratio, so this is a many times it's a confusing topic. So I'll try to simplify it. So what does delta ratio means? So the delta ratio is calculated in cases of high anion gap acidosis to find whether there is a hidden anion gap, hidden normal anion gap acidosis. So in normal anion gap, there cannot be a hidden, when there is a primary normal anion gap, there cannot be a hidden high anion gap. But in a high anion gap, there can be a hidden normal anion gap or even a hidden metabolic alkalosis. To find that, we uses delta ratio. So the commonest clinical scenario is in case of diabetic ketoacidosis, there will be initially the anion gap will be very high. We start correcting it. Gradually what happens is that our ketones, blood sugar starts improving, ketones become negative, but the acidosis alone persists. So what happens is, because of the excess chloride containing fluid we are giving, the patient develop a normal anion gap acidosis. So unless you don't look for the delta ratio, you won't understand why it is that there is a hidden normal anion gap. Okay, so in any patient, the change in bicarbonate and change in anion gap should be same in a high anion gap. So it means high anion gap means there is some extra acids, so that much bicarbonate would be decreased. That much bicarbonate is buffered, and that much, for example, if there are 5 extra acids, there should be 5 degrees in bicarbonate. That is the normal physiology. So that means the delta ratio normal would be, ideal would be 1 in a high anion gap metabolic acidosis. Now, what happens if the delta ratio is less than 1? So I'm taking time because it's a difficult topic. Okay, if the delta ratio is less than 1, that means that there was 5 extra acids, but the bicarbonate change was more than that. Bicarbonate change was 7. So what does it mean? There was 5 bicarbonate was used to neutralize the 5 acid, but there was some 2 extra bicarbonate. We have lost 2 extra. We have lost, apart from this buffered 5, we have lost 2 extra bicarbonate. Okay, so that means that there is patient is also losing bicarbonate by some other mechanism, which could be a hidden normal anion gap metabolic acidosis. So in a pure anion gap, it is 1.1 to 2 is normal. So 1.6 would be the value you expect in a lactic acidosis. Now, what if the value is more than acids in the body in a patient by 5, but the change in bicarbonate, it was more than 2. For example, you take it as 2 only. So what does it mean? So the patient has gained bicarbonate by some other mechanism. So even with 5 acids, patient has lost only 2 bicarbonate. That means the patient has gained 3 bicarbonate extra by some other mechanism. So it means that there is a concomitant metabolic alkalosis also in the patient. Okay. So just remember, delta ratio less than 1 means there is associated NAGMA, that is associated normal anion gap. More than 2 means that there is an associated metabolic alkalosis also in the patient. Okay. Now we'll again move to some clinical scenarios. So I'll just read out. A patient had a vomiting and diarrhea for 3 days. So she was not keeping, and she was having persistent loose stools, and she appeared lethargic and was cold to touch, and she had prolonged capillary time. So her ABG revealed pH of 7.2, PCO2 26, bicarbonate 12. So give your interpretation. So look at the clinical scenario. It is just simple diarrhea with hypovolemia with shock probably. A simple example.
Compensated metabolic.
Dr. Gayatri, any?
Sir, compensated metabolic acidosis.
Compensated.
Yes, sir. And partially compensated.
Okay, so please again. Okay, very good, very good. So again, compensated means your pH has to get compensated, right? So the pH is again 7.20. So simple, remember, if for ideal compensation, the pH had to increase and the Ca2 would have been 20, but it is 26 only. So you can, it is a partially compensated metabolic acidosis, simple. So just step by step, there is acidosis. Then look at respiratory or metabolic, look at 26 and 12. So the 12 is in the direction of acidosis. So it is a metabolic acidosis. Okay, then look at the respiratory compensation. Okay. Now second example, a 6-month-old child with recurrent pneumonia and loose stool. So this time admitted with an acute exacerbation, and he started improving. So we did his ABG, and this is his ABG. So he's a chronic pneumonia patient, pH 7.37, CO2 70, bicarbonate 40. So give your answer.
Sir, fully compensated respiratory acidosis.
Okay. Any other answers?
Uncompensated respiratory acidosis. Partially compensated respiratory acidosis.
Okay. Anything more?
Respiratory acidosis with metabolic alkalosis.
So excellent, excellent. So just take your own time. So it's simple, right? So it's what we discussed. So there is acidosis, absolutely no doubt about it. CO2 is increased, so absolutely it is a respiratory acidosis, absolutely no doubt here. Now coming to the compensation. So bicarbonate has increased. So the body has tried for metabolic compensation maybe. So what would have been the ideal compensation in so it's a recurrent pneumonia, so it's a chronic disorder. So we all remember it will be 1, 2, 3, 4. So in a chronic respiratory, it will be 3 change in bicarbonate for 10 CO2. So the CO2 is from 40, it has gone to 70. So it means 3 into 10. So the 3 into 3. So we would have expected increase in bicarbonate by 9. So the bicarbonate ideally would have been 24 plus 9, 33. But what has happened? It has gone to 40. So overcompensations never happens in body physiology. So it means that there is an associated metabolic alkalosis. Okay. So this is a classical ABG what you get in cystic fibrosis, where there will be both respiratory acidosis and associated metabolic alkalosis. Okay. So I think I made it clear. Okay. So final will be respiratory acidosis with metabolic alkalosis. Now,
can you explain the compensation?
Diabetic.
Sir,
yeah.
Explain the compensation once more. They are asking for the calculation.
Yeah, sure. Okay. So in metabolic acidosis, the change will be 1.2. So you just remember 1.2, 0.6, 1, 2, 3, 4. So this is for metabolic acidosis. There will be 1.2 change in the CO2 per change in bicarbonate. Metabolic alkalosis 0.6 change in bicarbonate per change in CO2 per bicarbonate. Acute respiratory acidosis, this is acute and this is chronic. Acute respiratory acidosis, there will be change in 1 bicarbonate per 10 CO2. In chronic respiratory acidosis, it will be 3 change per 10 CO2. So in this example, the CO2 is increased from 40 to 70. So it means it has increased by 30. Okay, so this is 3 change per 10 CO2. So for 10 CO2, there will be 3 increase in bicarbonate. Now it has increased by 30. So it will be 3 into 3. So the bicarbonate will increase by 9. So from 24 plus 3, so proper compensation in a chronic respiratory acidosis, the bicarbonate would have been 33. But instead in this example, it is 40. So overcompensation never happens. So that means that it is not overcompensation. There is a primary independent metabolic alkalosis. Okay. So in cystic fibrosis, body will be losing H plus and chloride. So that way body produces metabolic alkalosis. And because of CO2 retention, there will be respiratory acidosis. Both are independent disorders. Now, this is the patient with, we discussed previously, 10-year-old DKA. He was giving insulin infusion and fluid therapy. Okay, so by day 2, patient sensorium improved, but his acidosis was persisting. Ketones, maybe the ketones also became negative, but the acidosis was persisting. Bicarbonate still was 10. So what do you interpret from this? So the hint is look at the delta anion gap, look at the delta bicarbonate. Any answers, Gayatri?
No, sir.
Thank you.
Hello, Doctor.
High anion gap metabolic acidosis.
Okay. So what is the anion gap here? Anion gap will be 140 sodium minus chloride is 117, bicarbonate is 10. So 120. So by anion gap is 13. So definitely there is some high anion gap metabolic acidosis, but does that alone explain? So I discussed in high anion gap metabolic acidosis, you calculate the delta anion gap also and the delta ratio. So what is the delta ratio here is 1 by 14. So it is much less than 1. So it means that there is an excess chloride, there is an hidden normal anion gap metabolic acidosis also in the patient. Okay. Another way, see, look at the chloride. Chloride is very high. Okay. So another I'll just tell the definition of hyperchloremia is chloride by sodium. You can calculate the chloride by sodium ratio. If it's more than 0.79, it indicates that there is hyperchloremia. So hyperchloremia will cause acidosis. Okay. So in this patient, what I meant to say is there is acidosis, metabolic, partial compensation. So everything is correct. Anion gap is 13. So there is high anion gap metabolic acidosis, but the analysis is complete only if you interpret the delta ratio also. So there is both HAGMA and NAGMA here, right? So another example, 10-year-old child who presented with a 1 week history of fever was diagnosed with probably leukemia. He was tachypnic. SpO2 was 99% on oxygen. And we did a CBC which showed TLC was 2.5 lakh with blast. And because he was tachypnic, somebody did a ABG and found that his PO2 was 50. Okay, so because the SpO2 was again 99%, one enthusiastic resident, he repeated the ABG again and found that the PO2 was again 50. So how you interpret it and what you call this phenomenon? Any answers, Gayatri?
No, sir.
Okay, we are just 5 minutes more, so I'm just hurrying to the answer. So why this has happened? So there is a this is called pseudo-hypoxemia. Actually, the patient is maintaining 99%, but your ABG is showing hypoxemia. So why? Because because of this very high TLC, these leukocytes consume oxygen by mitochondrial respiration inside the blood, and they cause a pseudo-hypoxemia by the time we analyze the sample. Okay, so this phenomenon is called leukocyte larceny. Leukocyte larceny. Okay, so how you can avoid this? One is by analyzing the sample very fast. Other is by adding cyanide to the patient to the sample before analyzing. Okay. So why is the child tachypnic? The child could be tachypnic because of leukostasis. There could be pulmonary leukostasis. Okay. Now again, one example: a 5-year-old child with congenital myopathy or a chronic respiratory failure. He presented with some respiratory infection, and he was intubated in the emergency. And we did a ABG after 20 minutes, and we found this. So what is your interpretation?
So uncompensated metabolic alkalosis.
Okay, good. So here you have to look at this scenario. So there is definitely the person answered correctly. There is alkalosis. There is metabolic alkalosis. Okay. So in this case scenario, what is this phenomenon called? This phenomenon is called post-hypercapnic metabolic alkalosis. So what would have happened is, so in this congenital myopathy patients, usually they have a CO2 retention. Their CO2 is between 60 to 70, for example. Okay, and body would have maintained the bicarbonate level somewhere around 33, 34. Okay, so once he was intubated and ventilated, suddenly the CO2 was washed out. Okay, but the metabolic correction is going to take time. So what has happened? The CO2 suddenly we brought down to 40, but the bicarbonate was 33, which was his baseline. So which resulted in a metabolic alkalosis. So this is called post-hypercapnic metabolic alkalosis. Okay. 45 days old baby with history of recurrent vomiting from 3rd week of life. So this is a real-time example which was sent by one of my friend 2 days back. So you can see the pH is 7.57, PCO2 69, bicarbonate 62. This is a classical case scenario. You can see there is severe hyponatremia, hypokalemia also. Any answers, Gayatri?
No, sir.
So this is the classical.
So partially
Please
compensated
answer.
metabolic alkalosis.
Okay. So again, why I put this example is to teach one principle of compensation limits. Okay. So this is a classical ABG what we get in cases of hypertrophic pyloric stenosis. There will be severe metabolic alkalosis because of the loss of H+. Body will try to compensate by increasing the CO2, but the dictum in compensation is the CO2 never exceed 60 or never go below 10. There is a compensation limit. So if the CO2 has increased more than 60, it means that there is a primary respiratory acidosis apart from the compensation. Same holds with the CO2 less than 10. Okay. Same with bicarbonate also does not go beyond 40 by compensation alone. So if the bicarbonate is more than 40 or the CO2 is more than 60, it means that there is some respiratory acidosis also. So this patient presented apneic also. So there was metabolic alkalosis plus because of the apnea patient developed a respiratory acidosis also. So it's the last example, Gayatri. This is the last example. I take 2 minutes. So it's a Bartter syndrome. This is a slightly difficult one. Bartter syndrome. This is one of the difficult ABGs you can get. Any answers, Dr. Gayatri?
uncompensated metabolic alkalosis.
So bicarbonate is 16. So how you say this
Metabolic
alkalosis? Any
alkalosis,
other answers?
respiratory acidosis.
Okay, so I will
Metabolic acidosis plus
the
respiratory
pH is
acidosis.
6.9. So it is acidosis. Okay, so the primary disturbance is some acidosis. Okay, so both CO2 and bicarbonate are in the direction of acidosis. So the simple answer would be respiratory. It's a mixed acidosis, respiratory plus metabolic acidosis. Okay, now. Okay, so now this is a slightly difficult example. I'll explain. But now look at the case scenario. The case scenario is Barthes syndrome. So in Barthes, what you expect is loss of bicarbonate and metabolic alkalosis. So in this patient, there is a metabolic acidosis contrary to the expectation. So if you look at, so in any metabolic acidosis, you have to look at the anion gap. So here the anion gap would be 142 minus chloride plus bicarbonate. So it is the anion gap is very high. The anion gap it is 39. Okay, so there is a high anion gap metabolic acidosis. So respiratory acidosis plus high anion gap metabolic acidosis. The next step would be to look at the delta ratio. So if you look at this delta ratio in this patient, the delta ratio was delta anion gap was 27 and delta bicarbonate was 9. So delta anion gap was 3. It was more than 2. So what does it mean? There is an associated metabolic alkalosis also in the so because of the time limit, I feel I had to hurry through the examples. It would have been better if I had got more time. And maybe if you are interested, you can contact me in this WhatsApp number or mail ID. I feel I should repeat this class. I'm myself not satisfied with the class. And you can give the feedback, and because the Zoom session is not going to cut now, so I feel I needed more time to complete it properly, and I needed to give you more time to go through the examples.
Thank you, sir.
Dr. Gayatri?
If anyone of you have any doubts, type in the chat box, or you can unmute yourself.
They can share, they can ask you. Any comments in the chat box?
Thank you very much. It was very nice, but little fast.
Yeah. So
it was wonderful.
Dr. Gayatri, I think because time is up. I think the time is up. So based upon the feedback, I think we can consider one more class.